I'd like to thank the meeting organisers for this invitation to give a presentation, and I'd like to now give you a short update on diabetes therapies and weight loss, by which I mean glucose lowering therapies that have been introduced largely to manage type 2 diabetes, but have now begun to permeate into weight management licenses. So these are my disclosures. And quite a lot of this talk is based on a article that I wrote in a journal called the British Journal of Diabetes that was commemorating 100 years of insulin, called Fat Pharmacological Therapies. And the background to the article is highlighting that until the launch of GLP-1 receptor agonists, which was globally around 2006, and then the SGLT2 inhibitors, which was around 2011, 2012, we really didn't have therapies that were effective at glucose lowering, but also had a beneficial impact on weight reduction. And this is clearly important because it's generally seen that the driver behind the epidemic of type 2 diabetes has been the increase in sedentary lifestyle and weight that we see throughout most of the world. And so having therapies that would lead to weight reduction was clearly an important benefit. We had metformin for 70 years or whatever, but I think metformin's largely either weight neutral or an insulin sparing medication that then gives a degree of weight reduction due to lower levels of insulin. But in terms of proper weight reduction, these two classes were real game changers. Now, it was recognized early on that the weight reduction seen with SGLT2 inhibitors was due to the glucosuria, so the loss of glucose in the urine that they induce by their mechanism of action on the kidney. And so it never seemed likely that you would get significant calorie loss and therefore weight reduction in people who were non-diabetic. And indeed, that has been shown to be the case, that the change in weight in people who don't have diabetes at the time of initiation of these medications is relatively small. So to my knowledge, there are no plans to move SGLT2s into the arena of weight management. However, the converse has been true with the GLP-1 receptor agonists, where reduction in weight does not appear to be dependent on glucose levels. So GLP-1 then, this is what it is. The human GLP-1 molecule is on the top left here, and this is secreted by L cells in the small intestine in response to absorption or the ingestion of carbohydrate and food in general. And GLP-1 is known to have various mechanisms of action. It enhances insulin secretion in a glucose-dependent way, meaning it only does it when glucose levels are high. It reduces glucagon secretion, but it also has an impact on satiety. I think originally we felt that this was due to a reduction in gastric emptying, but we now know that there are direct effects on the satiety centers in the brain, and that leads to a reduction in food intake, and as a consequence of that, weight reduction. So liraglutide was the first GLP-1 receptor agonist. You can see liraglutide in the middle panel here is very closely related to human GLP-1, and this was investigated in a higher dose than used for glucose lowering for the possibility of weight reduction. And liraglutide, a dose of 3 milligrams once daily. Note the top glucose lowering dose is 1.8 milligrams once daily, was marketed as Saxenda, and the general concept was that it would reduce food consumption by reducing hunger, inducing a feeling of satiety, and that would lead to a reduction in overall weight, partly down to visceral fat reduction, but also subcutaneous fat reduction. And the important thing was that it wasn't having this effect by increasing energy expenditure, because that has always been something that has caused a degree of alarm bells, because previous medications that have worked in this way have had some deleterious cardiovascular effects. So liraglutide was subjected to a phase 3 trial at this high dose, known as the SCALE set of studies. So the SCALE obesity and pre-diabetes, SCALE diabetes, and SCALE maintenance, and SCALE sleep apnea studies. So you can see these are large numbers of individuals. They were all placebo-controlled trials, and as is the case with most obesity studies, they were of a extended duration, so typically 68 weeks. So what were the outcome of the SCALE studies? Well, this is looking at the 3 milligram liraglutide dosing in the dark blue bars here, and these are comparisons with placebo. And this is looking at the weight reduction that has been seen in terms of greater than 5% and greater than 10%. And I think it's important to bear this in mind, these percentages, as we go through the talk, and you'll see how these sort of achievements have changed. So the reason for the 5% weight reduction target, if you like, is that that's what the FDA, the Food and Drug Administration in the United States, regard as a weight reducing therapeutic. So if a drug can achieve that level of weight, then they'd be prepared to consider it as a treatment for weight loss. And you can see that with the 3 milligram dosing, 56 weeks here, 63% of people were hitting that 5%. This is versus 27 in the placebo group. And if you go for a tighter target, then 10% of weight reduction from the baseline was being achieved, in about a third in this study here. Looking at SCALE diabetes, a long 56-week study again, and you're seeing about half of the patients were achieving this 5% weight loss, and about a quarter were hitting 10%, and in the sleep apnea study, about 46% getting more than 5% weight reduction. So clearly this is a drug at higher than doses than typically used for glucose lowering, is achieving substantial amounts of weight reduction, which I think is something that we'd not really seen with previous medications in the past. In terms of side effects, desperately common. Obesity itself is a condition that you really don't want to be inducing serious adverse effects for the treatments that you're using. You can see that the side effects that we're seeing were largely those that you would expect with a drug, and especially a drug from the GLP-1 receptor agonist class. So nausea, vomiting, diarrhea, and constipation. The GI upsets were common, and those are exactly what we have seen in studies looking at type 2 diabetes. So Saxenda came onto the market as glucose lowering, but at the same time that Saxenda was coming out, we were beginning to get the once weekly GLP-1 receptor agonists launched for glucose lowering therapy in type 2 diabetes. So liraglutide, I mentioned, was highly homologous with human GLP-1, so 97% homology. Semaglutide has got an extra amino acid change, which gives 94% homology, and it's linked to this fatty diacid chain virus base, which allows for strong binding to albumin and gives prolonged action. And this is a now weekly version that many of you will know for glucose lowering, known as Ozempic. So once again, the plan was to look at higher doses in individuals with overweight and obesity, and this is known as a STEP program of studies. And you can see here that these are 68-week studies. You can see the baseline that they were starting with and the mean weight loss that was seen 15%, 16%, 17%. So generally speaking, semaglutide at a dose of 2.4 milligrams once per week was achieving substantial weight loss. But if I go back to the graphs that I was showing you for Saxenda earlier, this is now looking at the individual numbers of people achieving a 15% weight loss. So you will recall that at 5% weight loss, it was about 50% of the individuals in the trials were getting that weight reduction, 50% getting 5%. Now you've got 50% plus that are getting a 15% weight reduction. Note that the achieved weight reduction seen in type 2 diabetes were less. 25% were getting that sort of weight loss. And this is a recurring theme throughout all obesity-related trials, that individuals with type 2 diabetes just seem to lose less weight than those who don't have diabetes. And that's something that's currently unexplained, but certainly a common feature. So that suggests that semaglutide once a week is better than liraglutide once a day, and that was finally confirmed, or firmly confirmed, with this publication in JAMA in 2022 that compared semaglutide with liraglutide at the 2.4 versus the 3 milligram doses, and about 16% of people were getting substantial weight loss versus about 5% of those with the liraglutide. And this step 8 study was showing that once weekly is definitely better than once daily. The impact of this, even in a country as conservative with new medicines and indeed regarding obesity as a target for therapeutic drug intervention, even in the UK, there was an acceptance that this was a substantial result. And in February 2022, semaglutide at high dose, also known as Wegovy, was made available, in theory at least, via the NICE, National Institute of Clinical and Healthcare Excellence, regulatory approval. So NICE recommended the drug. The reality of it has been that we have only just begun to introduce it in the UK in around January 2024. And certainly in my area of Wales in the UK, the number of individuals who can access this medication is extremely low. And you can see that the inclusions of a BMI above 35 kilograms per meter squared is basically a lot more restrictive than was seen in the clinical trials. Now, this is partly a financial issue, but the other thing that has certainly developed on the back of the benefit seen with semaglutide has been these massive shortages of GLP-1 receptor agonists throughout the planet. Certainly the Ozempic shortage remains with us. I think we're anticipating that there'll be shortages of Ozempic and Victoza, which is liraglutide, until the end of this year, that's 2024. And this is largely blamed on individuals being prescribed glucose-lowering therapies for weight reduction, and often being able to get hold of these medications via online internet services, rather than in the UK, for example, it would be entirely down to prescription otherwise. So the global shortage that we've seen of GLP-1 receptor agonists has been down to the benefits of weight gain that have been reported. What about tirzepatide? So tirzepatide is the first of the dual agonists. It's a GLP-1 and a GIP receptor agonist, a single molecule that interacts with both of these receptors. Once again, like semaglutide, it's a once weekly drug administration, and this is certainly extremely powerful in terms of glucose lowering. So these are the SURPASS trials that were all done in individuals with type 2 diabetes. SURPASS 2 is particularly interesting because here this is not a placebo-controlled trial. This is a trial comparing with the standard high dose of semaglutide for glucose lowering, that's Ozempic. And you can see that in terms of glucose lowering, there is a good glucose lowering effect to get HbA1c less than 6.5%, which is 48 millimoles per mole, interestingly, with a relatively modest dose-related escalation in glucose lowering, but certainly in the SURPASS-2, it was better than seen with Ozempic. But if we now look at the weight reduction in that trial, and note that we're now looking at trials in individuals with diabetes, type 2 diabetes, I've already told you they do less well in terms of glucose reduction. And if you compare with the scale trials that were 68 weeks, these are 40-week or 52-week studies, you can see that the weight reduction is better, and it's better than was seen with Ozempic. And there is definitely a dose response here. So going from the lower maintenance dose, which is 5 milligrams once a week, up to the top maintenance dose, which is 15 milligrams once a week, tirzepatide is giving substantially more weight loss. So 40% and 53% of people achieving loss of their baseline baseline levels. Now, subsequently, we have seen studies done in people who do not have diabetes, and this is the SURMOUNT-1 trial. And here you can see that with the higher dose of tirzepatide, 15 milligrams a week, the overall mean body weight from baseline is nearly 21% versus a placebo loss of 3.1%. And looking at this graph here that's looking at the time since randomization at the bottom, there's an impression that maybe the baseline has not been reached. Now, if you look at those body weight reduction targets now, here's the 5%. You'll recall that was hit by about 50% of people in the scale trials. Well, it's been hit here by 91% of individuals on the higher dose. And if we go to the 15%, we're seeing 70% of individuals hitting that target. And then a third of individuals in the SURMOUNT-1 trial were getting a more than 25% reduction in their body weight. So massive weight reductions being seen with this drug. As a result of this, interestingly, the ADA-EASD that produced its latest consensus in 2022 has now got a big focus on weight reduction as part of the glycemic management. And note that semaglutide that I've been describing as Wegovy and tirzepatide were both mentioned as being highly efficacious drugs for glycemic control, but add on to weight reduction. And I think it's particularly interesting that neither of these drugs yet has got evidence of cardiovascular superiority demonstrated in clinical trials. So the SOUL trial is looking at oral semaglutide, but the result will be applied to injectable, and the SURPASS CVOT is looking at tirzepatide, but neither trial has yet reported. So having been totally focused on cardiovascular outcomes and evidence-based therapies, ADA-EASD has sort of just relaxed things a little, going for individuals, the weight reduction being the most important thing. Now, does fat reduction reduce cardiovascular outcomes? This is a paper as recently as May 2022, which highlighted the fact that we hadn't shown using drugs that reducing weight equated to benefits in terms of cardiovascular disease, which is a major cause of morbidity and mortality in this group. And here suggesting that maybe high weight and low weight were both associated with increased risk. So fortunately, as of last year, we now have the results from the SELECT trial. This was a trial looking at over 17,500 individuals who were overweight or obese with established cardiovascular disease, but were not known to have diabetes, and indeed at randomization had an HbA1c less than 6.5%. This was powered to detect cardiovascular superiority. It was event-driven, which means it was looking at cardiovascular events as a composite, this being non-fatal MI, non-fatal stroke, and cardiovascular death. And it was a comparison of placebo with semaglutide in the higher 2.4 milligram once weekly dose. And these were the headline results. The cumulative incidence of MACE, which is major adverse cardiovascular events, was reduced by 20%, so a hazard ratio of 0.8. Two lines begin to diverge relatively early during the trial, and this is significant. Pardon me, significant for superiority at the p equals 0.001 level. So for the first time, we had evidence that use of a glucose lowering drug at high dose leading to weight loss would actually produce cardiovascular benefit. So having produced that data, we are now seeing many other drugs that are coming through as potential glucose lowering drugs being examined in weight reducing trials with a view to showing benefit not only in weight but also cardiovascular disease reduction. So this is the first dual agonist that, rather than having GIP agonism, as is the case with tirzepatide, has got agonism of the glucokinase receptor. And as I mentioned earlier, this is particularly important because it's likely that weight loss induced by glucagon receptor, glucagon agonism, is down to increased energy expenditure. And so there will definitely have to be evidence of cardiovascular safety with this preparation. But this is a trial that is now being set up, known as Synchronized Cardiovascular Outcome Trial, and this is looking at time to first occurrence of the adjudicated components of MACE, in this case a 5-point MACE, which will also include angina and other cardiovascular elements. So Synchronized CVOT is a trial that is ongoing at present. There's also another injectable which includes semaglutide, but also is including cagrilintide, which is an amylin, a human amylin agonist. And so these are together in a dual cartridge or dual container syringe pen device, injected at the same time, once again on a weekly basis. And the REDEFINE trial is looking at lower doses of so-called CagriSema purely for weight management. So these individuals in this study will not have diabetes, so they'll be excluded on the basis of an HbA1c above 6.5%, but it will be looking at the typical obesity trial duration of 68 weeks and comparing placebo with different doses of CagriSema, with a trial objective to confirm benefit in terms of weight loss from initial treatment. And then finally, the ultimate, I guess, is a triple agonist, and retatrutide is one of those. So this is not only a similar product to tirzepatide, having GLP-1 and GIP agonists, but has also got agonism of the glucagon receptor. So we have a situation with agonism of the three incretin drugs, agents here, and this is a TRIUMPH outcomes trial, which is a phase 3 randomized double-blind placebo-controlled trial, which will investigate the effect of retatrutide on the incidence of MACE, major cardiovascular events. And you can see here highlighted below that this is people with and without type 2 diabetes. So once again, with a big focus on weight reduction of what you might anticipate would be a major glucose lowering therapy. So things have been moving very swiftly since the initial trials, the SELECT trials looking at high dose liraglutide. We've now moved into the high dose semaglutide Wegovy era. Tirzepatide has now got a license in the United States for weight management. Certainly in the UK, that's not the situation yet, but I'm sure it will come through. And then we have this slew of other agonist drugs that are increasingly moving away from glucose lowering as their major therapeutic target to that of weight reduction in the diabetic and indeed non-diabetic population. So exciting times. We now have better trial evidence regarding cardiovascular outcomes for weight management drugs than we've ever had before, and the newer drugs will go down a similar line to having that sort of trial evidence to support their use in clinical practice. So I'd like to thank you for your attention, and I shall stop at that point.